One way that the cancer care field is changing now is in the adjuvant setting. So we've gotten a drug approval, well, 2 drug approvals now for melanoma, and are able to use ipilimumab and nivolumab in the adjuvant setting. And that, of course, has generated a lot of excitement, knowing that we can give patients that relapse-free survival benefit by treating them for a year with immune therapy. And I think the question, of course, that comes up is, think about all the other patients that are faced with that adjuvant discussion, and that almost inevitably involves radiation and chemo or some combination. So can we think about it in adjuvant breast and adjuvant colon and adjuvant lung and adjuvant fill in the blanks? So I think that's a big way that the field has changed in terms of how we think about how these treatments can benefit not only patients with metastatic disease, but patients with early stage disease who are just at just as much risk of later possibly dying from their cancer. I think another way that the field is continuing to evolve is there a role for chemo and radiation with immunotherapy? I think that a lot of people think of immunotherapy as a distinct and separate treatment silo, and you treat someone with that therapy, but then you move on to a different one. And in reality, it probably is going to play well in the same sandbox as chemotherapy and radiotherapy. And how do we design those treatments so that we can get the best therapeutic impact up front and extend that patient's survival? So we need to start thinking about these treatment modalities as not independent of one another.